Yes, thank you, Babak. And thank you also in my name for the previous presenters and a very nice session and the interesting Q&A that it was leading to. So in the second session, we'll move on to more to the clinical application. So we just discussed methodological aspects, and in this second session, we will be looking at the evaluation of effects of spinal disorders on both motion and loading. So again, I would like to ask all speakers to stick to their 8 minutes appointed time. Also, again, a warm welcome to all attendees and participants to raise questions during the presentations through the Q&A option of Zoom. As mentioned during the previous session, of course, it's also possible to raise hands in the common discussion section at the end of this session. And with that, I would like to welcome our first speaker of the second session. That will be Mr. Sayed Musavi from the Beth Israel Medical Center in Boston, USA. The floor is yours.
Okay, thank you. Good morning, everyone. Thank you for the opportunity to present our work here. Can you see my screen?
Yes, perfectly. Thank you.
Right, thank you. So the topic of my presentation is walking biomechanics and spine loading in patients with spinal stenosis. Lumbar spinal stenosis is a common degenerative spinal condition and a leading cause of pain and mobility limitation in older adults. Symptomatic lumbar spinal stenosis, generally called neurogenic claudication, is typically caused by narrowing of the spinal canal, which can compress the lumbar nerves, particularly when the lumbar spine is in extended or lordotic postures. Trunk flexion or bending forward postures or leaning on a shopping cart can provide some relief. Therefore, it is widely believed that patients with LSS adopt compensatory forward flex postures that improve tolerance for walking by relieving pressure on the nerves. However, there's a controversy in the recent motion analysis literature. The purpose of our study was to evaluate trunk posture, particularly lumbar spine and pelvis angle and lumbar spine compressive loads in standing and walking, and to determine the effect of the pain and symptoms on trunk posture and spine loading in patients with symptomatic lumbar spinal stenosis. So we hypothesized that patients would display increased trunk flexion posture and spine loading during walking and in the presence of claudication symptoms. So 7 participants, 4 women, 3 men with symptomatic LSS aged 44 to 82 underwent a 3D optoelectronic motion analysis during standing and walking trials in pain-free and symptomatic states. Passive reflective marker clusters were attached to participants at T1, L1, and S2 levels, with additional reflective markers at other spinal levels, as well as the head, pelvis, and extremities. To produce the symptomatic state, participants perform a standard walking capacity test on a motorized treadmill at a self-selective pace until reporting the onset of the symptoms, up to a maximum of 30 minutes. A whole body musculoskeletal model was created for each participant, incorporated with our established model of the thoracolumbar spine. Inverse kinematics and static optimization were used to quantify kinematics and loading variables during standing and walking. The outcome of pelvic tilt, spine flexion plus pelvic tilt, and lumbar compressive load were averaged across one gait cycle. Postural outcomes were referenced to the asymptomatic neutral standing. Our result showed that pelvic tilt and spine flexion plus pelvic tilt were larger during walking than pain-free standing, and additionally increased during symptomatic walking. However, spine flexion wasn't different in walking than in standing and didn't increase with the symptoms. Pelvic tilt in symptomatic walking was larger than pelvic tilt in both pain-free standing and asymptomatic walking. In symptomatic standing, we saw a small but significant increase in pelvic tilt versus pain-free standing. Lumbar loading was increased by an average of 22% during pain-free walking. Loading in symptomatic standing wasn't larger than pain-free standing, while loading during symptomatic walking was possibly increased by an average of 4% over pain-free walking. So as a conclusion, our results indicate a forward shift of the entire trunk during both pain-free and symptomatic walking in patients with symptomatic lumbar spinal stenosis, supporting our overall hypothesis. This was primarily due to increased pelvic tilt and not flexion of the spine. Interestingly, while most patients increased pelvic tilt, the effect on spine posture were variable, and on average suggested extension rather than flexion. In fact, 2 patients displayed the largest amount of spinal extension, perhaps suggesting a compensatory action to maintain overall balance. Estimates of spine loading suggested possible increase in spinal compressive loading in the symptomatic state, but the magnitude of any such change wasn't likely to be consequential. So the lack of increased spinal flexion seen here is not consistent with the commonly held assumption that patients with lumbar spinal stenosis adopt flexed spine posture to increase spinal canal diameter and decompress the nerve, thereby relieving or delaying symptoms. So a possible explanation is that while forward bending or trunk flexion are temporarily effective in reducing symptoms, walking with trunk flexed position is posturally unstable and energy inefficient, as it demands compensatory motions and higher muscular activity to maintain dynamic balance. This may soon lead to general or local muscular fatigue, forcing patients to stop or limit their walking. In addition, increased spine loading due to higher muscular activity or fatigue may provoke or aggravate the symptoms. So additional study of walking and spine biomechanics in this population is needed to better understand this issue. While small sample size is one of the limitations of this study, our study is the only one tested walking biomechanics in pain-free and symptomatic states and measured spine loading in these conditions. We're also following up our patients after decompression surgery, so decompression with or without fusion, to see the effects of the treatment, the effect of surgical treatment on spine posture and loading and walking biomechanics. And our current preliminary results showed satisfactory results showing that we can see some changes after the surgery regarding both trunk flexion, spine loading, and other kinematics variables. Thank you for listening to my presentation, and I'm happy to take your question. Thank you.
Thank you a lot, Dr. Mousavi, for this very interesting lecture. We have one first question popping up while we're switching presenters to the next one from Dr. Babak, one of our panelists as well. So please, Babak.
Yep. Thank you, Jawad, for the nice presentations. You indicated changes in spinal load due to changes in posture. Can you give like your opinion about how about changes in like neuromuscular behavior or muscle force due to pain itself, not the changes in posture? Because with pain, neuromuscular behavior is going to change, muscle recruitment is going to change. How is that going to be affecting like a spinal load?
Yeah, that's correct, and that maybe affect the loading. But one thing that we can consider is that it's just a small walking trial, and that also pain may affect the muscular activity, and that contributes the loading. And we We acknowledge that, but that effect might be aligned with the change in the trine posture, and we should consider both of them to see if it's just the pain is affecting the spine loading or change in the posture and its effect on the spine loading. So that's interesting. Yeah,
because if I understand correctly, your model is an optimization-based model for prediction of muscle force, and it's been stated that people with pain may co-activate their muscles, and optimization-based model cannot capture those co-activation. Yeah, thank you, Jawad.
Okay, I think with that we have time for one quick second question, and that's from Dr. Hemmenschott. Did participants walk at the same self-selected speeds between pain-free and symptomatic trials? So again, linking to the standardization discussion we just had. So please, Mr. Moussaf.
We didn't have a standardization for the self-paced walking, but before the testing, we asked subjects to walk along the lab to find their self-selected space, but it was just up to them to walk at what the speed that they choose.
Yeah, and then was there an effect on that self-selected speed? That's well, the actual question between the pain-free and the symptomatic trials that you noticed in your data.
So definitely after having the symptoms, the walking change, the self-selected pace or the speed, and the pattern of the walking change.
Okay, thanks. With that, I would like to move on to the second speaker, who is Mr. Seman from Saint Joseph in Beirut, Lebanon. So please, Dr. Seman. You will have to switch displays because now we're currently seeing your presenter mode. So on display settings on the top, please switch to switch screens. So while Mr. Seman is setting up his presentation, I'll already mention the title of his talk. So Dr. Seman will be talking about walking alterations in adult spinal deformity and their dependence on the type of deformity, specifically in adult spinal deformity. Yes, now we can nicely see your presentation. So please, the floor is yours. You might want to unmute yourself.
Here we go.
Yes.
So adult spinal deformity is a pathology that is increasing with the aging of the population. ASD classification is based on the following radiological criteria for SVA: thoracic kyphosis, coronal curve angle, and pelvic tilt. A recent study conducted by our group showed that patients with adult spinal deformity had walking kinematic alterations that were associated with a deterioration of quality of life. However, it is still unknown which spinal deformity component from the ASD classification affects the gait pattern. Therefore, the aim of our study was to evaluate kinematic alterations during walking in ASD patients with different types of spinal deformity. 82 ASD patients were enrolled, as well as 63 controls with the following demographic and inclusion criteria. All subjects underwent a radiographic evaluation using EOS Biplanar X-Rays with 3D reconstructions of their skeletal segments and the calculation of the following 3D radiographic parameters, such as thoracic kyphosis, lumbar lordosis, pelvic tilt, sagittal vertical axis, and coronal curve angle. The ASD population was divided into 3 subgroups: 25 patients in the ASD frontal group presenting only a coronal curve angle higher than 20 degrees, 36 patients in the ASD sagittal group presenting at least one of the following parameters, either an SVA higher than 50 millimeters or a pelvic tilt higher than 25 degrees. And finally, 21 ASD were classified in the ASD hyperkyphosis group, presenting only a thoracic kyphosis higher than 60 degrees. All participants performed 3D gait analysis based on plug-in gait model using 41 markers as described by Davis and Riardini in order to extract lower limbs, pelvis, and trunk kinematics. The gait deviation index was also calculated. They also filled the following quality of life questionnaires, such as SF36 with its physical and mental components, as well as the ODI. Kinematics and postural parameters were compared between ASD subgroups and control. Determinants of gait alterations were explored among postural radiographic parameters in each group. So in the next slides, in the following figures, color blue represents ASD frontal subjects, orange represents ASD sagittal subjects, gray represents ASD hyperkyphosis, and green represents control. First, we've noticed that the gait deviation index was the most affected in the ASD sagittal group. We also noticed in the kinematics of the lower limbs that the ASD sagittal group has a decreased range of motion of the pelvic obliquity and the pelvic rotation. The ASD sagittal group showed also a reduced range of motion of the hip flexion extension during the gait cycle, as you can see on this graph. Moreover, the ASD in the sagittal group also had a decreased knee flexion in swing, as well as a decreased range of motion of the knee during the whole gait cycle. We also noticed that the ASD sagittal group had a flexed thorax during gait compared to the other groups, as well as a reduced dynamic lumbar lordosis L1, L3, L3, L5. When we looked at the time distance parameters, subjects in the ASD sagittal group had a slower walking speed, a decreased cadence, a longer double support time, and a shorter step length, most probably in order to ensure stability during walking. We've also noticed that these patients had the most affected quality of life scores compared to the other groups, as we can see here on the physical component of the SF36 and the ODI. When we investigated the determinants of the kinematic abnormalities, we found a correlation between the gait deviation index and the sagittal spinal deformity, such as the SVA and the pelvic tilt. And we can see that the increase of SVA and pelvic tilt, especially in the ASD sagittal group in orange, was correlated to the deterioration of general gait behavior. If we look into the detailed kinematics, we can notice that an increase of SVA and/or pelvic tilt was associated with a reduced mobility of the knee flexion extension and also a reduced walking speed. In conclusion, the study showed that sagittal spinal malalignment is the main driver of gait alteration in ASD. In fact, patients with higher SVA or pelvic tilt tended to walk slower with shorter steps in order to maintain stability during walking, associated with a limited flexibility in the pelvis, hips, and knees, as well as a flexed attitude in the thorax, hips, and knees. These findings showed the importance of differentiating between ASD patients depending on the type of the deformity. Thank you for your time and your attention.
So thank you, Mr. Saman, for a nice presentation. So as questions are hopefully coming in through the Q&A, I will take the liberty to ask a first question. So you specifically used the gait deviation index in your study, which is a well-known ensemble parameter that mainly focuses on the lower limbs. Do you see as part of possible future work, an extension of the GDI to make it more spine specific? And if so, how would you approach that, or what would your recommendations be?
Yes, it's a very interesting idea. We should look forward to improve in our next studies. We should look forward to improving this remark.
And what's the GDI, your normality scores for the GDI, so the features that underlie its calculations, did you quantify them on your control group, or did you use...
Exactly. It was compared to the controls group. to take it as the baseline as the Lebanese population.
Okay. And then a second question, while the next presenter can prepare to put his presentation up. The Gait is, of course, a sagittally oriented motor task mainly. So do you think, or would you predict similar changes and differences between subgroups to occur in more complex motor tasks that extend from that pure sagittal direction? So for example, gait-related turning tasks such as sidestepping turns, etc. Do you think that would be an interesting motor task to investigate?
Yeah, it's a very interesting idea, and we are working on it already. My colleague will present the task of sitting and standing, and to pass from the position sitting to standing and standing to sitting. And we are as well giving our patients the task to make the stepper evaluation as well as the rapid march self-speed.
Okay, thanks for that. And then in the sake of time, we'll move to the next presenter, who's from the same group, Ms. Albir Massad, and she'll be talking about the association between gait alterations and quality of life in patients with adult spinal deformity. So please, Ms. Massad, you may put up your presentation. And it's coming up. Okay. Yes, so you may end.
Okay.
Yeah, perfect. Go ahead.
Thank you. I'll be talking about the association between gait alterations and the quality of life in patients with adult spinal deformities. Just one moment, because I'm not. Okay. A high prevalence of spinal deformity has been reported in elderly, where 32 to 68% of individuals over 65 years old present spinal deformity. And this is related to the rapidly aging of the global population. According to the International Spine Study Group, 4 radiographic parameters characterize ASD patients, as explained below for the SVA, thoracic kyphosis, coronal cob angle, and pelvic tilt, with the presence of pain and discomfort. Health-related quality of life questionnaires have become an inherent part of the evaluation of ASD patients, where several studies have reported significant correlations between radiographic parameters and health-related quality of life questionnaires. However, the relationship between functionality and quality of life in ASD patients has not been reported yet, knowing that functionality can be quantified objectively using motion analysis. So the aim of the study was to investigate the contribution of gait kinematics along with radiological parameters in determining quality of life in subjects with ASD. Is it working? Because my colleagues are telling me that it's not showing.
I can see your presentation perfectly fine and can hear you fine.
Okay, so, sorry, I'll keep on.
I also see nothing in the.
Okay, so our aim was to investigate the contribution of gait kinematics along with radiological parameters in determining quality of life in subjects with ASD. So 52 subjects with ASD were enrolled in this study with a mean age of 43 years old, presenting pain and discomfort, and with no history of lower limb surgery or recent spine surgery. All participants performed a full body biplanar X-rays using EOS in order to calculate radiographic parameters related to the spine, to the pelvis, global alignment, horizontal gaze, and to the coronal plane. They performed a 3D gait analysis as well in order to calculate gait parameters related to the time distance parameters, kinematics related to the lower limbs, pelvis, and trunk. And in order to evaluate the overall gait alterations, the gait deviation index were generated as well. Visual analog questionnaire, visual analog scale questionnaire served to assess the level of pain in all participants. And in order to evaluate the physical disability and mental health, all participants filled the SF36, ODI, and VDI. In order to, relationship between quality of life scores and gait parameters was studied. And in order to define the determinants of quality of life, a multilinear and hierarchical regressions were conducted. ASD subjects enrolled in the study presented spinal deformities, and they showed moderate disabilities in terms of physical and mental health. Concerning the correlations result, BDI was correlated to the horizontal gaze, indicating that subjects with a downwards oriented gaze have higher depression score. The visual analog scale was negatively correlated to the overall gait alterations quantified by GDI. The static forward shift of the trunk, quantified by the SVA, was correlated to the physical component scale of SF36. This was also found during gait, where the thorax flexion was correlated to ODI, indicating a loss of functionality. The hip and knee range of motion in the sagittal plane were both correlated to the physical component scale of SF36, and this implies that a limitation of their kinematics will affect PCS and therefore functionality. When explanatory variables of patient-related outcomes were investigated among radiographic parameters only, PCS was determined by SVA and Cobb angle. The model investigating determinants of PCS among gait parameters only showed that hip extension and stance and shoulder pelvis axial rotation were the main determinants. When a mixed model was applied, while controlling for demographics and sagittal parameters, it has been shown that hip and pelvis kinematics could explain up to 74% of physical component score. Concerning ODI, it was determined by SVA among radiographic parameters and by the step length, thorax flexion extension, and the hip flexion extension among gait parameters. And however, when a mixed model was used, it has been shown that step length and hip kinematics can explain ODI up to 73%. While radiographic parameters solely could explain up to 50% quality of life score and gait parameters up to 63%, the current results show that a combination of radiographic and gait parameters creates a model that can explain up to 74% quality of life alterations in ASD patients. So in conclusion, this analysis showed that gait analysis is a crucial element in ASD assessment. From a functionality point of view, it should be used complementarily to radiographs for an optimal comprehension of quality of life alteration. Hip, pelvis kinematics, and step length have a major role in explaining the alteration of quality of life in ASD. Is the correction of these parameters the driver of the improvement of quality of life? Future studies should focus on the evaluation of treatment outcomes based on quality of life questionnaires, radiographic assessment associated with gait analysis. Thank you for your attention.
So thank you, Ms. Massad, for this nice presentation. We have a question from Babak as one of the panelists. So please, Babak, feel free to ask your question to Ms. Massad.
Yep, thank you for the presentations. My question is on the relationship that you reported on trunk flexion versus disability, ODI. Can you elaborate on that and just maybe explain a little bit more about how you compare that relationship with the relationship between trunk flexion and pain?
We didn't find a correlation between trunk flexion and pain quantified by the visual analog scale. However, we found this correlation with ODI, which is related to physical disability. These are our preliminary findings for this study. So we didn't find this correlation.
But you reported
in dynamic during walking, because we know in static position, it has been reported that it might be correlated with pain because it's an antalgic position. But in dynamic during walking, they are not bending their trunk, or at least this correlation was not found during gait.
between trunk flexion and pain, right?
Exactly.
But how about between trunk flexion and disability? You found some correlation,
yes,
right?
Yes, we found this correlation between trunk flexion and ODI.
And it was
which implies physical disability.
So like the more disability, you found like larger trunk flexion during walking?
Yes, it was larger during walking.
Okay, thank you.
Okay, thank you. For the sake of time, I suggest we move on to the last speaker from the same group. So again, from Saint-Joseph de Beirut, Mr. Adi Saad, who will be talking about the alteration of the sitting and standing movement, again in adult spinal deformity. And if I may invite again to all attendees to please raise your questions in the Q&A. That would be very welcome. Thank you.
Stop share.
Okay, we can see your presentation. So the stage is yours.
Okay, thank you. I will be presenting about sitting and standing movement in adult spinal deformity. With the aging of the population, there has been an increase in the prevalence of degenerative diseases, and in particular adult spinal deformity or ASD. Adults with spinal deformity are known to have spinal malalignment, along with compensatory mechanisms, both of which can affect the quality of life of the patients and have repercussions on their daily life activities. Traditional evaluation of ASD subjects include clinical examination, radiographs, and quality of life questionnaires. Motion analysis is increasingly being used in order to better characterize functional alterations seen in ASD. A study that was conducted in our lab has shown that ASD patients walked slower with an increased double support time and maintained a flexed attitude of their thorax, hips, and knees. The importance of motion analysis is also emphasized by the fact that gait kinematics, along with radiographic parameters, were able to explain up to 90% of quality of life alterations seen in ASD. But what about other daily life activities? Sitting and standing represent an important daily life activity that is frequently used during the day. In fact, the inability to stand up in the elderly is correlated to an increased risk of dependence and even of mortality. Sitting and standing also represent a complex task that requires fine-tuned musculoskeletal coordination. And therefore, the aim of our study was to evaluate sitting and standing kinematics in ASD with different types of spinal deformity and their relationship with their quality of life scores. Our population consisted of ASD subjects aged more than 20 years old and fulfilling at least one ISSG criteria. Control subjects were also recruited. They did not fulfill any ISSG criteria and did not have any pain or history of spine or lower limb surgery. All subjects underwent 3D radiographic evaluation using the EOS Biplanar X-ray system with subsequent calculation of 3D spinopelvic parameters. And so our population of ASD was subdivided into 3 subgroups. ASD was a frontal malalignment presenting with only a coronal cup angle superior than 20 degrees. ASD was a sagittal malalignment presenting with an SVA that was higher than 50 millimeters and or a pelvic tilt higher than 25 degrees. And finally, ASD was an isolated hyperkyphosis presenting with a thoracic kyphosis superior than 60 degrees. All subjects underwent motion analysis using a modified plug-in Gait protocol based on 41 markers as described by Davis and Leardini. The following body segments were also reconstructed: lower limbs, pelvis, thorax, head, and spinal segments, and kinematics were extracted. All subjects were asked to sit on a seat without a backrest, the height of which was adjusted so that the hips and knees were at a right angle. And the subject was asked to stand up and then sit down while looking straight forward. All subjects also filled the following quality of life questionnaires: the SF-36 with both its physical and mental components, the score of which decreased with the severity of the alteration, and the Oswestry Disability Index, the score of which increased with the disability. Demographic, radiographic, and kinematic parameters were compared between the 4 subgroups, and relationships were explored between kinematic alterations and quality of life scores. Our population consisted of 33 ASD individuals with a sagittal malalignment, 23 with a frontal malalignment, 19 with an isolated hyperkyphosis, and 28 controls. In the standing position, as expected, ASD with a sagittal malalignment presented with an increased pelvic tilt and SVA, along with a decreased lumbar lordosis. ASD with a frontal malalignment presented only with a coronal cup angle that was increased, and ASD with an isolated hyperkyphosis also presented with an increased lumbar lordosis. Quality of life scores were altered in all ASD subjects, but more importantly, in those with a sagittal malalignment. The charts below represents kinematic parameters during the sit-to-stand movements. The color yellow represents control, blue represents ASD with a frontal malalignment, orange those with a sagittal malalignment, and gray those with an isolated hyperkyphosis. As you can see here, ASD with a sagittal malalignment presented with a decreased hip flexion during sit-to-stand. They also presented with an increased flexion and extension range of motion in their heads. ASD subjects with a sagittal malalignment, along with those with an isolated hyperkyphosis, presented with a more flexed thorax during sit-to-stand. Furthermore, ASD subjects with a sagittal malalignment presented with a decreased flexion and extension range of motion in their lumbar segments L1, L3, and L3, L5. ASD with a sagittal malalignment and those with a hyperkyphosis presented with an increased flexion and extension range of motion in their cervical thoracic spine, C7, T2, and T2, T10. Similar results were also observed in the stand-to-sit motion. All of these sit-to-stand kinematic alterations were correlated to the quality of life deterioration seen in ASD. As you can see in the first graph, the increased head mobility in the sagittal plane was correlated to a more severe disability, as shown by the ODI score. Also, the increased cervical thoracic mobility in the sagittal plane was associated with a more severe deterioration of the physical component of the SF-36. And so, ASD individuals with sagittal malalignment present with a more flexed thorax during sit-to-stand. They also present with an increased lumbar rigidity and an increased range of motion in their head and cervical thoracic spine. ASD with an isolated hyperkyphosis presented with similar but less pronounced results. Our study limitations include demographic heterogeneity. However, even after controlling for confounding variables using ANCOVA analysis, the same alterations persisted. We are also increasing the number of subjects in each of our subgroups. In conclusion, sitting and standing movements are altered in ASD, more importantly in those with sagittal malalignment, and to a lesser degree in those with an isolated hyperkyphosis. There were no kinematic alterations seen in ASD with an isolated frontal malalignment. Therefore, it is important to subdivide our ASD population in order to better characterize the kinematic alterations. The kinematic alterations seen in ASD included an increased thorax flexion, a decreased lumbar range of motion, and an increased head and cervical thoracic range of motion. All of these kinematic changes were correlated to the deterioration of quality of life seen in ASD. We are currently carrying out a post-op evaluation of ASD subjects in order to see whether surgery was effective in restoring normal sit-to-stand kinematic and improving the quality of life of our patients. Thank you for your attention.
So thank you, Eddie, for your presentation. For the sake of time, I suggest we move on to directly to the last speaker of this session. And then please, possible questions for Mr. Saad can be asked during the general discussion at the end. So Mr. Ribera, the floor is yours, and I happily look forward to your presentation on the assessment of dynamic sagittal balance during walking in patients with adult spinal deformity. So please, Mr. Ribera from Paris, France.
Hello, thank you for the introduction. Shifting global population, shifting global population age was introduced by the United Nations in 2017. And in fact, nearly 22% of world's population will have more than 65 years old by 2050. This aging process induce degeneration of intervertebral disc that leads to segmental deformities, and so compensatory mechanism that leads again to postural changes. These changes affected the prevalence of musculoskeletal disease as ASD, age spinal deformity. Thus, there is a clinical consensus on the radiological definition of ASD, including pelvic tilt, sagittal vertical axis, thoracic kyphosis, frontal curve. And all those radiographic parameters are correlated to quality of life scores of patients. More recently, a new parameter, the odontoid hip axis angle, ODHA, was introduced. It's usually an invariant parameter that assess the head position relatively to the pelvis. So this parameter assesses the global postural changes in static. But as you saw, postural malalignment is usually assessed on static radiograph. However, to answer the quality of life concerns of this patient during gait on daily life activities, a functional evaluation should be suggested during those daily life activities, such as walking. Thus, the aim of this study was to assess postural malalignment in ASD during walking by evaluating dynamic sagittal balance. To do that, in our population, this population was constituted of 69 ASD patients, 62 asymptomatic subjects. Here you can find the age and the sex proportion of those population. Subjects were equipped of reflective markers on the head, trunk, and lower limbs. And they all underwent a 3D gait analysis with a Vicon system at self-selected speed. EOS Biplanar X-Rays were taken with the marker still in place in order to reconstruct the 3D bones, and that allows us to construct the transformation matrix for each segment between the EOS cabin and the Vicon system. Then image registration was performed during gait in order to compute a kinematic mean value of pelvic tilt, SVA, and ODHA during gait, with a special look the mean value and the sway of the ODHA. When we look to the ODHA angle during gait cycle, we can see that the corridor of normality of the controls group have a mean value of 1 degree with a standard deviation of 5 degrees. So we decided to divide our ASD population according to this corridor of normality. All ASD who had their ODHA during gait above this corridor were grouped in the ASD dynamically unbalanced group. Otherwise, ASD who had their ODHA inside the corridor constitute the dynamically balanced group. So these were the mean waveform for the ODHA during the gait cycle. In green, you have the control group, in blue the ASD balance group, and in red the ASD dynamically unbalanced group. What we can see is that we have an elevation of the mean value of ODHA during gait of 7 degrees between the unbalanced group and the other groups, but also a small increase of the sway of the ODHA during the gait cycle. So the findings are that the head is advanced during the gait for the unbalanced group. We also noticed that both groups of ASD have the pelvic tilt increased during gait as a compensatory mechanism for their spinal deformity. However, so all our ASD patients presented a pelvis retrogression. However, only the ASD dynamically unbalanced ASD couldn't keep their head above their pelvis. When we look into the detail of the group who was dynamically unbalanced, for the radiographic parameters, like it was shown before, we noticed that this group had an increased pelvic tilt, SVA, an increased thoracic kyphosis, and cob angle. And by looking the kinematic parameters, we found that this group presented a flexion attitude for the thorax, hip, and knee, a decreased mobility for the pelvis, hip, and knee, and a lower walking speed and a lower step length. We can also notice that this group of ASD unbalanced had the most affected ODI compared to the other groups. By looking to the ODHA, we notice that these parameters correlate better to the ODI than the dynamic SVA and the dynamic pelvic tilt. So dynamic ODHA can better explain the quality of life concerns of these patients. So we wanted to know what parameters could drive this dynamic ODHA, and we make a multiple correlation. In fact, 49% of the dynamic ODHA have been explained with radiographic and kinematic parameters. And among all the explanatory variables, the range of motion of the knee, flexion extension, was the most influential parameters, and it was highly correlated to the ODHA. So, to conclude, in this study, we evaluated the dynamic variation of postural parameters like SVA, pelvic tilt, and ODHA. We also have found that the ASD dynamically unbalanced patients had their head advanced during gait, presented a deteriorated quality of life associated with altered spinopelvic alignment and kinematics during gait. And the major finding of this study is that the dynamic ODHA parameter is related to quality of life scores of these patients, and that's one of the major determinants of dynamic ODHS is the knee flexion extension range of motion, showing that physical rehabilitation of knee mobility could have an impact on the relative position of the head to the pelvis during walking for the patient with severe deformities. Thank you for your kind attention.
So thank you, Mr. Ribera, for your presentation and sharing your useful insights. With that, I would like to open the general discussion and invite all session panelists to join in the discussion. So apparently the questions that have been raised during the presentations have already been answered in written form. So please allow me then to well, I see an upcoming question from Mr. Van Dien. So please, Mr. Van Dien, you have the floor to pose your question.
Okay, thank you very much, Mr. Chairman. I have a comment, not so much a question, regarding the last couple of presentations. I'm really concerned about the way correlations are interpreted here. I mean, these are statistical correlations, and I hear terms like determinants, drivers, and those interpretations are really a step too far, in my opinion. couldn't resist commenting on that.
Mm-hmm. Yes, I see what you mean. The fact that it seems to imply that there's a causal relation between the measurements, the dynamic measurements being performed, and then a possible effect in terms of the pathology. Is that what you're referring to?
Well, both to, let's say, the correlation between the gait kinematics and quality of life. I mean, it's a far-fetched to assume that that is a causal relationship. There may be very many, let's say, mediators and confounders and spurious correlations involved. But also, like the knee flexion being a determinant of the trunk posture, it could as well be the other way around. So I think we have to be much more careful in interpreting correlation.
Yeah, I fully agree, and I think this is like a common thing in specifically the adult spinal deformity literature, that there's this reliance on looking at correlations between possible input measures and then health-related quality of life.
Can I
Sure.
Yeah, make my comment, because we were trying in these studies just to find a way to explain deterioration of quality of life in ASD patients based on a functional exercise, because we know that the quality of life is mostly based on mental health, physical abilities. So we are just trying to find this bridge between how to quantify this quality of life based on kinematic analysis, and our results showed that we can. We can, in the same statistical study we've conducted, we found that we can more explain these alterations based on functional exercise or kinematic data related to the gait, more than static analysis based on radiographic assessment. So we are trying just to more understand what's the factors that are altering this the quality of life in this population, and to find a way how to evaluate treatment outcomes based on such assessments. So
yeah, but please keep in mind that correlation does not imply causation. So it's by no means, the correlations you show by no means tell us that these kinematic parameters do predict or cause changes in quality of life. They're merely correlated.
Yes, sure. Thank you for your question. Yes.
Yeah, no, but I do see a lot of value in trying to indeed, that's the other side of the medal, of course, to try to better understand like relations indeed between this dynamic functionality and well, quality of life as a general outcome measure, because there's a heavy reliance on radiographic parameters, and that brings me, since I don't see any other questions, so if there would be other questions, please feel free to raise your hand. So another general question towards the panel from this session. How do you see the possible translation of these dynamic assessments into routine clinical practice towards the future? Because there are some recurrent problems in all methods that we apply. First of all, there's the cost, of course. On the other hand, there's the high amount of data that typically results from our dynamic assessments. So there's a need for data reduction. So please, if someone would like to comment on that concern.
Maybe I can say a word. We saw in the literature that low-cost motion systems are coming with pretty interesting results. So maybe the path to clinical routine will be with a GoPro system or anything low cost. It will not be for the next year, but I think that it will be a good asset to improve those low-cost motion capture system in order to put the motion analysis into a clinic routine.
I agree there. So Any other panelists who would like to comment on the possible pathways to implementation in clinical practice?
If I can comment that for instance, I will be talking about sitting and standing kinematics. As we have seen in our study, we have seen that there is a lumbar rigidity in these patients, but however, there's an increased mobility in the upper segment. And we know that surgical treatment, usually in ASD subjects, can increase the rigidity of the spine. And this might help us, or the evaluation, preoperative evaluation of ASD patients might help us know how rigid their spine actually is and what are the segments that are the more rigid. And this could help us tailor our surgical technique in order to prevent complications.
Dr. Assi, you wanted to comment on this as well.
Yes, thank you, Dr. Skies. Actually, I agree with you that we need to reduce the number of data, but first, I guess it's still very preliminary, and we don't have enough data to understand a lot the spinal deformities, and especially from a functional point of view, and not only walking but also the other daily life activities, as you mentioned earlier. So here we presented the stand movement, but also to present other movement, and then maybe when we have some of more of description of the all the abnormalities and where are the abnormalities, how are the compensatory mechanisms put in place, then we can decide maybe later on what are the most meaningful parameters, most meaningful data that we have to acquire in order to better understand the functionality of the patient and how to better treat these patients. And I also agree with you that maybe functional analysis is important by doing motion capture, 3D motion capture, using for gait analysis and other daily life activities. But here too, I guess not all labs are equipped, or all the clinicians have the 3D capture machines or equipment. So maybe here we have to think about new techniques of low-cost motion capture in order to have this functional assessment for these patients.
Okay. Yes, thank you, Ayman, for those useful insights. So if I may summarize then, I hear in this discussion a call for more data, more standardization again is definitely also a recurrent theme, and a call to the community and then for more low-cost systems to allow this translation to clinical care and to the clinical floor. And with that, I would like to end this session. We'll have a short 5 to 7 minutes break. So happy to reconvene at 11:10 for the last session of today that will be shared by Professor Dennis Anderson. Thank you. So happy to welcome you all back at 11:10.